Hello everyone, my name is Essmaeel Abdel-Dayem. It's my pleasure to speak with you today about artificial intelligence and how it's transforming the practice of medical imaging. It's an honor to be able to contribute to this conference. I'm sorry that the timing did not allow me to be there in person, but I am with you all in spirit, and I'm very grateful to the organizers, Dr. Hosna Mustafa and Dr. Walid Omar, for inviting me to participate. Let me start by telling you a little bit about myself. I am a radiologist at South Shore Radiological Associates. We're a private practice group comprised of about 30 radiologists covering one of the busiest community hospitals in the state of Massachusetts. And we partner with the Brigham and Women's Hospital and the Dana-Farber Cancer Institute to offer cancer care to our patients. I mostly specialize in body imaging and interventional radiology. And prior to my current position, I was at the Massachusetts General Hospital in the Division of Abdominal and Interventional Radiology, and I worked to help develop the community and teleradiology practices there. Now, you might be wondering, do I have a background in computer science? No. Do I have a background in data science? Also no. So why am I speaking to you about AI today? Because I, like most radiologists, find myself in the midst of a technological shift that's rapidly reshaping our field. We are navigating a complex and changing environment, trying hard to integrate powerful AI tools responsibly while maintaining the highest standards of patient care and honoring the trust our patients place in us. But this is not just about radiology or medicine. As a society, we are at the dawn of a new industrial revolution, one fueled by rapid technological advancement. Like every revolution before it, it demands a shift in mindset, a commitment to using AI responsibly, maximizing its benefits while addressing potential risks. And here's the critical point. Whether or not we have a background in AI, it's our responsibility to educate ourselves. This technology is not just coming, it's already here, and it will redefine the future of our field. If we do not take the initiative to understand and guide its integration, others will do it for us. We have to engage, we have to educate ourselves, and we have to lead in order to make sure that the advancement of this technology is centered around the well-being of our patients. Okay, so with that, let me give you a quick overview of what we'll be covering today. First, I'll start with a brief introduction to AI, breaking down some of its key elements and how they relate specifically to medical imaging. Then we'll explore some of the opportunities and applications of AI in our field, and I will highlight a few of the exciting ways it's being used today. While there's enormous potential, there are real obstacles to implementing AI, technical, regulatory, and ethical, that we need to navigate carefully, and I will discuss some of those. And finally, I will wrap up with a brief look at the future of AI in medical imaging, and most importantly, our role in shaping that future. I'm starting with this chart from a 2023 J&M article because I think it nicely illustrates how advancements in medicine have paralleled the different stages of the Industrial Revolution. And it shows how AI is not a standalone development, but is part of the continuum of technological innovation. The first and second industrial revolutions from the late 18th century to the early 20th century gave us mechanization and electricity. These advancements brought innovations such as the EKG and X-ray, which made it possible to see inside the human body for the first time, revolutionizing diagnosis and treatment. The third industrial revolution, or the digital revolution, gave us computing technologies that extended these abilities. CT scanning and ultrasound provided a safer, non-invasive way to visualize soft tissues and significantly expanded our diagnostic capabilities. Now, in the fourth industrial revolution, AI and big data are enabling us to process vast amounts of information, integrating imaging, laboratory data, wearable device data, and more to improve our understanding of human biology and disease states, paving the way for enhanced prognostic modeling and personalized treatment planning. As radiologists, we've always adapted to new technologies. AI is no different. It's transforming our field, and it's up to us to ensure it's implemented thoughtfully and ethically. This is a picture of Geoffrey Hinton, often called the godfather of AI for his pioneering work in deep learning and neural networks, which formed the foundation of much of modern AI and earned him the 2024 Nobel Prize in Physics. In the radiology community, however, he's probably best known for a now infamous statement he made in 2016. He said, "I think if you work as a radiologist, you are like the Wile E. Coyote in the cartoon." So here's a picture of Wile E. Coyote in case you don't remember from your childhood. He said, "You're already off the edge of the cliff, but you have not looked down yet. There is no ground underneath. People should stop training as radiologists now. It's just completely obvious that in 5 years, deep learning is going to do better than radiologists." So needless to say, this was upsetting to a lot of people, and many who were considering specializing in radiology diverted to other paths, fearing that the specialty would soon be obsolete. This exacerbated an already short supply of radiologists. But it's now more than 5 years later, and it's clear that radiologists are needed more than ever. And it's clear that we shoulder a wide array of responsibilities that are not easily replicated by AI. There's a quote by the American futurist Roy Amara which says, "We tend to overestimate the effect of a technology in the short run and underestimate the effect in the long run." The situation is analogous to the development of self-driving cars. Just as we were promised self-driving cars years ago, there are many obstacles that have kept us from taking a nap in our car on the way to work. It's 2025, and I'm still a working radiologist with little help from AI, and I still drive myself to work every day with little help from self-driving cars. As the technology continues to evolve, we will need radiologists more than ever, just as I need to monitor my car and my surroundings as computers take over some of the mundane tasks of driving. Radiologists will need to redefine their role as AI takes on the more routine tasks we do every day. And just as I need to choose the destination my car is driving towards, we will need to determine where we are headed with AI. Radiologists will play a crucial role in shaping how AI is integrated into clinical workflows, ensuring it aligns with our ultimate goals of improving patient outcomes and advancing medical care. We will need to interpret studies by integrating AI-provided data, evaluating its accuracy, and modulating it for the best outcomes. With advancements in molecular imaging, radiomics, and genomics, AI can help us contextualize and manage the vast new data at our disposal to enhance patient care. So with that, let's begin with an explanation of some of the common terms you will hear when discussing AI. This slide shows the relationship between artificial intelligence, machine learning, and deep learning. AI is a broad concept. It refers to any technique that allows computers to mimic human intelligence or perform tasks using logic, such as decision trees or, if A, then B type rules. Within AI, we have machine learning. Machine learning is a subset of AI that uses statistical techniques to improve at tasks with experience. It's all about training a model to learn patterns in data and apply that learning to make predictions or decisions. A step further is deep learning, which is a specialized subset of machine learning. Deep learning uses multi-layered neural networks that can train themselves to perform tasks like speech and image recognition by processing large data sets. So here's the difference. In traditional machine learning, such as CAD for breast imaging, radiologists and programmers have to identify and encode specific features into the program. For example, characteristics like shape or texture or calcification are manually extracted before the machine learning model classifies the image as benign or malignant. With deep learning, this manual feature extraction step is eliminated. The model handles both feature extraction and classification steps on its own. You simply provide a large data set of labeled images, say benign or malignant, and the deep learning model figures out which features are important to consider when classifying them. This ability to learn directly from data without manual or human intervention is what makes deep learning so powerful and transformative, and can in fact end up teaching us about the features that end up being important in diagnosis. Okay, there are a couple more terms that I think are important to know. The first is natural language processing. NLP is a branch of AI that allows computers to understand, interpret, and generate human language in a meaningful way. This is what many of us are using on our phones every day when we use Siri or Alexa or Google Assistant. In radiology, NLP is good for tasks that involve language, so things like extracting important information from reports, identifying critical findings to aid in decision-making, and automating report generation and checking for errors in our reports. It's also well suited for tasks like data mining across imaging archives or EMRs, and it's great for tracking follow-ups and recommendations to make sure patients don't fall through the cracks. The second term I think is important is convolutional neural networks, or CNNs. CNNs are a type of deep learning model specifically designed to analyze visual data, which makes them very effective for medical imaging tasks. CNNs function in much the same way that our biological neural networks do. For example, when we see an image of a cat, our brain breaks it down into components like 4 legs, it has a tail, pointy ears, and whiskers, then processes this information through neural networks to identify it as a cat. Similarly, CNNs take input images and break them down into little pieces to extract features, then process them through an artificial neural network to identify and classify an image. In radiology, CNNs detect patterns in imaging studies to aid in diagnosis, automate a segmentation of anatomical structures and disease, and help improve our efficiency in patient care by prioritizing studies that have critical findings. They also facilitate computer-aided detection and radiomics, helping uncover valuable insights for early disease recognition. This is one of the most cutting-edge applications for this technology, and we will look at this in more detail later. So where does AI fit into clinical practice? The short answer is everywhere. This RSNA workflow diagram highlights how AI can integrate into every step of the imaging process. Before imaging, AI can help the ordering clinician select the right study, make sure the study is protocoled correctly, and can help screen for key patient factors like allergies, renal function, and BMI to optimize contrast or tracer doses. It can also help forecast staffing needs, making sure the proper subspecialists, such as neuroradiologists, nuclear medicine specialists, or interventional radiologists, are scheduled to cover the case mix. At the image acquisition stage, AI helps with image reconstruction, noise reduction, dose optimization, and improving image quality, all while reducing scan times. Once the images are acquired and reconstructed, the data is then sent to PACS. Here, an AI orchestrator plays an important role making sure that the appropriate AI models are applied to each exam. For example, in a stroke patient undergoing a CT angiogram, the system might apply algorithms to detect brain hemorrhage and large vessel occlusion, but it might also apply algorithms for incidental findings, say in the lungs or thyroids or the bones. After the AI models process the images, they can prioritize the radiologist's work list, making sure urgent studies are flagged and brought to the proper radiologist's attention. This is especially crucial in high-volume practices where emergency departments are generating hundreds of imaging studies every day. AI can identify acute findings and notify not just the radiologist, but also the appropriate clinical team, such as the stroke or trauma service. During interpretation, AI can help the radiologist detect abnormalities and automate time-intensive tasks such as segmentation and measurements, significantly reducing the time required to analyze the study. AI also helps with report generation by incorporating measurements, auto-generating impressions and differential diagnoses, and suggesting follow-up recommendations based on standardized criteria such as BI-RADS or lung-RADS. This can help reduce variability between radiologist reports and improves overall patient care and confidence. After reporting, AI can help make sure that follow-ups are scheduled, notifying patients and care teams when follow-up imaging is overdue. And finally, it aids in billing tasks like insurance pre-authorization, coding, and submissions, ensuring that we can keep our practices running smoothly. Here's a similar chart from an article published in the JNM in 2023, which also nicely outlines how AI can be applied to the imaging pipeline both before and after the image acquisition. AI applications before the imaging process are often referred to as upstream AI and include AI assistance in radiopharmaceuticals and radiochemistry, image acquisition and reconstruction, and post-reconstruction image enhancement. AI applications after image acquisition are referred to as downstream AI and include image analysis and segmentation, detection and diagnosis, radiomics, as well as enhanced reporting and clinical decision support. So as you can see, AI has the potential to enhance every step of the imaging workflow, driving advancement in diagnostic accuracy, workflow efficiency, and patient care. Let's break down some key opportunities and applications. As we saw in the previous two slides, AI can automate repetitive tasks like image preprocessing, report generation, and data analysis. Automating some of these tasks frees up radiologists' time to focus on more complex cases and to interact with referring physicians. AI can improve image quality by reducing noise and artifacts and can optimize radiation dose during imaging procedures while maintaining image quality and minimizing radiation exposure. Automated lesion detection. We see a lot of this in nuclear medicine and in screening. AI algorithms can automatically segment and highlight suspicious areas in medical images, such as abnormal areas of FDG uptake, assisting radiologists in identifying and quantifying abnormalities more efficiently. Enhanced diagnostic accuracy. By identifying findings in imaging that we may have missed, either because they are hard to see or because our attention is drawn elsewhere or because of satisfaction of search, or frankly because we're human and we get tired, AI can improve our sensitivity and specificity and help catch our errors before it's too late. AI can help unlock hidden value in imaging data by extracting insights that go beyond traditional image interpretation. One example of this is opportunistic screening, where data from routine imaging studies like lung cancer screening CTs can be used to detect other things like coronary artery disease, can help assess bone density, or evaluate body composition, all without any additional imaging, just using the data that is already in the study. In combination with radiomics, AI can go even further by extracting quantitative features that may actually be invisible to the human eye to help predict treatment response or help in prognosis. I will give some examples of this later on. Early cancer detection. Along the same lines, AI can identify small, potentially cancerous lesions in scans like mammograms, CT scans, and MRIs, enabling earlier diagnosis and treatment when cancers are more treatable. Prognostic modeling and personalized treatment. AI can help analyze patient data to generate tailored treatment plans based on individual characteristics and disease progression. Bridging gaps in care. In situations where a radiologist is not immediately available, having some level of interpretation is better than none. In these settings, AI can help emergency physicians have more confidence in interpreting X-rays and CT, especially when the question that will affect the clinical decision-making is limited. For example, intracranial hemorrhage, PE, stroke, or trauma. Similarly, AI can help bridge gaps in radiology coverage in underserved areas that may have very few radiologists, and also in disaster situations. And finally, AI can transform radiology education with personalized learning tools, simulated scenarios, and performance analytics, ensuring radiologists stay ahead in a rapidly evolving field. All right, let's go a little deeper and look at some examples of the highlighted items above. So let's start with image enhancement and denoising. Deep learning reconstruction allows us to generate higher quality images from less data. This means we can use lower doses of radiation, tracer, or contrast while still producing images that meet or even exceed diagnostic quality. So obviously in nuclear medicine, the noise in the image is going to depend on how much tracer is injected and how long you scan the patient. So basically there's a big opportunity to train AI here, as you can take a shorter scan duration and the full scan duration to create a training data set. Then you can use the data set to train an AI model to take a high noise, subsampled image and create a low noise diagnostic image. You can find lots of studies like this in the literature, and I've included a couple of examples here to demonstrate how these groups were able to train models to generate near full quality images with a quarter of the counts. These techniques can be applied across multiple modalities, including MRI, CT, PET, and SPECT. This capability allows us to maximize the diagnostic value of every study while reducing risk to patients. Another important use of AI is automating the time-intensive process of lesion detection, segmentation, and quantitation. In PET imaging, we often aim to quantify the amount of cancer within a patient. For example, in lymphoma cases, measuring the metabolic tumor volume can be challenging but provides significant value in predicting patient outcomes and evaluating tumor response. On the left, you can see an example in lymphoma. The green contours represent those drawn by the physician, while the purple contours are generated by the AI method. Overall, the AI performs well, but the authors included two notable outliers. Here in the middle panel, you can see that the model overestimated the amount of disease in the retroperitoneal nodes. And here on the right, you can see that there's additional disease in the right lobe of the liver that was missed by the AI model. On the right-hand side of the slide, we see a similar approach applied to head and neck cancer, where AI helps automate radiation therapy treatment planning using PET images. Beyond oncology, this technology has obvious applications in cardiac imaging, renal scintigraphy, gastric emptying studies, VQ scans, and HIDA imaging. Whether it's calculating ejection fractures or measuring volumes or segmenting structures, AI can significantly reduce the workload for physicians and technologists who have traditionally performed these tasks manually. For oncology patients with serial scans, AI enhances the uniformity of reports and provides valuable insights into therapy response. Additionally, with the growing role of theranostics in nuclear medicine, AI will be instrumental in estimating disease burden and guiding treatment strategies for targeted therapy. Here's another example of automated detection and segmentation, this time in lung cancer. This is from an article actually just published last month in Radiology. This was a retrospective study using an AI model that was trained on over 1,500 CT scans containing over 1,800 segmented lung tumors, and the model was tested on 150 CT scans. The results were impressive. The model achieved 92% sensitivity and 82% specificity in detecting lung tumors. The images on the left show the clinical segmentation in orange on top and the AI model segmentation in blue on the bottom. As you can see, the AI model is very close to the clinical segmentation. And here are a couple more images from that same study showing how well the AI segmentation performed as compared to the clinical segmentation. So up until now, we've focused on how AI can assist with labor-intensive tasks, but its potential extends far beyond improving efficiency. In fact, its most important application may be in helping us unlock the power of radiomics. So what is radiomics? This is a quote from an article in Radiographics from a few years ago, and I'm going to read it. Radiomics refers to the extraction of mineable, high-dimensional data from radiologic images that has been applied within oncology to improve diagnosis and prognostication with the aim of delivering precision medicine. The premise is that imaging data convey meaningful information about tumor biology, behavior, and pathophysiology, and may reveal information that is not otherwise apparent to current radiologic and clinical interpretation. So this last sentence, this last part, that's what's important. May reveal information that is not otherwise apparent to current radiologic and clinical interpretation. It's the idea that there is information in the imaging data that we cannot perceive with our human senses. But by combining radiomics with machine learning, we can extract this data to better serve our patients and advance precision medicine. So here's an example. This is a paper from the Mayo Clinic from a couple of years ago that looked at combining radiomics and deep learning to see if they could detect pancreatic cancer on pre-diagnostic scans. So what are pre-diagnostic scans? These are imaging studies performed for any unrelated reason, such as trauma or hematuria, that happen to include the pancreas. What they found was that radiologists, even retrospectively looking at scans from 2 to 3 years ago, may not see a tumor in the pancreas. However, using machine learning, AI can evaluate radiomic signatures or fingerprints to identify tumors in the pancreas that are invisible to the human eye. So in this case, AI is showing us things that we as humans cannot detect on our own. The study showed that AI could detect subclinical pancreatic cancer with a median lead time of 386 days before clinical diagnosis, and this offered a critical window for possible surgical cure. To show you what this looks like, here's a figure from that paper. On the left is a pre-diagnostic scan on a patient that developed pancreatic adenocarcinoma nearly 9 months later, and on the right is a control study for comparison. Below is a color-coded textural overlay where you can see there's a distinct difference between the pre-diagnostic and control studies that would not be apparent to the radiologist with the naked eye. Again, the pancreas on both of these studies was read as normal, even in retrospect. While clearly more work is needed before this can be brought into clinical use, the potential here is incredible, not just to diagnose cancer earlier, but also to understand the longitudinal changes in carcinogenesis that occur before clinical diagnosis, improving outcomes for a notoriously difficult to detect disease like pancreatic adenocarcinoma. Breast cancer screening is another field where this concept is being applied. So this is an interesting story. In 2014, a computer scientist at MIT by the name of Dr. Regina Barzilay was exploring the use of AI to interpret dead or extinct languages when she was diagnosed with breast cancer. This experience, combined with her journey through treatment, inspired her to explore whether AI could be applied to detect breast cancer earlier. She partnered with Dr. Constance Lehman, a leader in breast imaging at MGH, to develop a predictive model for breast cancer called Mirai. Using data from 128,000 mammograms, including 3,800 scans that led to cancer diagnoses within 5 years, they created a software that can predict the likelihood of developing breast cancer within the next 5 years. The accuracy of the model was impressive, ranging from 75% to 84%. AI tools like Mirai are now being incorporated into clinical practice. To catch cancer earlier, we need to predict who is at risk before symptoms arise, and AI has made this kind of forecasting possible. So, after their success with breast screening, a friend of Dr. Barzilay was diagnosed with lung cancer, and the team began to wonder if they could make an AI model for that also. So again, through a collaboration at MGH, the team developed another model called Sybil. Sybil uses low-dose CT scans to predict a patient's future lung cancer risk. This slide shows examples where Sybil identified high-risk cases in patients that had unimpressive initial scans, so lung grads category 1 and 2 cases, but where the patients later went on to develop lung cancer. Some of these cases, like the first one here in panels A and B, did not even have a visible nodule on the initial scan, but was still assigned a high-risk score by the AI model. I won't go into too much detail with the other examples because of time, but by identifying subtle patterns that human readers can easily miss, they were able to show that this software can improve early detection, reduce missed cancers, and help personalize screening strategies instead of using a one-size-fits-all approach. All right, we've covered some of the opportunities that AI brings to the table. Now let's shift focus to the obstacles that prevent AI from entering clinical practice. One of the biggest challenges AI faces in radiology is navigating regulatory and validation hurdles. The process of obtaining FDA clearance is time-consuming, often taking 1 to 2 years, and it's expensive, costing anywhere from $250,000 to $1 million. Additionally, AI models are designed to change over time and improve. This requires constant updates and revalidation to ensure they continue to perform safely and effectively in clinical practice. Without continuous validation across diverse populations and healthcare settings, these models risk underperforming or even failing in real-world applications. Liability is a significant concern when implementing AI. Who's responsible when an AI system makes an error? The radiologist, the institution, the AI vendor? It's unclear, and this uncertainty creates a medical legal gray area that is very problematic and not easy to resolve. Bias and a lack of good data sets are another big problem in AI. Bias in AI models can be introduced from training on non-representative data sets, which can lead to healthcare disparities. We can use the example of self-driving cars. Computers trained to drive in these situations are not going to perform well in these situations. They both involve cars and streets, but the context is completely different. So we need high-quality, diverse, and well-labeled data sets to train AI so that it can perform well in different environments with a variety of different hardwares and in diverse populations without leaving anyone behind. These data sets will need to be open source so everyone can benefit while still maintaining patient privacy. Drift and hallucinations. As I mentioned earlier, AI systems are not static. They can drift over time as they learn and adapt to new data. This can lead to performance degradation in different settings or populations. Additionally, hallucinations, where AI generates inaccurate or non-existent findings, pose a risk to diagnostic accuracy. Continuous quality assurance processes similar to those used for medical imaging hardware are necessary to monitor and maintain AI performance. AI integration is also hindered by a lack of standardization in radiology systems. AI tools must seamlessly work with RIS, PACS, and other systems, but differences in infrastructure and a lack of interoperability standards across different vendors and institutions make this difficult, and it makes groups hesitant to invest significant funds into a platform or software that may soon end up becoming obsolete. So establishing strong interoperability standards will be important to encourage investment in AI technology. Finally, there's the issue of cost. Who's going to pay? Developing and deploying AI is expensive, and hospitals are often hesitant to invest without a clear return on investment. While AI can improve efficiency and throughput, reimbursement from payers remains limited. Payers will likely ask us to recuperate our costs from increased efficiency. So if hospitals are hesitant to invest, radiology practices may need to collaborate with other practices such as cardiology or oncology that could benefit financially through increased patient referral. Ultimately, proving AI's value in terms of time savings and improved outcomes will be essential to driving adoption. Okay, so we've come to the end. I hope you leave today feeling inspired about the future of radiology and of medicine as a whole. AI is bringing incredible new capabilities to our work, things that until recently we could only imagine. AI presents us with enormous opportunities. It has the power to bring incredible efficiency to our work, to help us detect cancer earlier than ever before, and to help us unlock the power of radiomics and precision medicine. But with this promise comes responsibility. Over-reliance on AI is a risk we must manage, particularly for less experienced clinicians. We'll also need to ensure that AI algorithms remain accurate and reliable, and that they are being used ethically. It's no longer a question of if, but when AI will become fully integrated into our clinical practice, and we need to start now to be prepared for the future. In this process, I think it's clear that radiologists will not be replaced, but our roles will evolve to focus on how to responsibly integrate all of this vast new information into improved patient care. So in a way, radiologists that embrace AI as a new tool for practice will replace those that do not. In the near future, AI will always be at our side, helping enhance our clinical accuracy with advanced pattern recognition and automation. But we will need to provide our best clinical judgment, our appreciation for clinical context, and compassionate, human-centered decision-making that AI just can't replicate. This collaborative approach will free us up to focus on the more complex problems we face as physicians, as well as the deeply human aspects of our profession that perhaps inspired many of us to pursue careers in medicine in the first place. So, in conclusion, AI isn't here to replace us. It's here to transform how we work and what we can achieve. It can help us create a better future, not just for radiology, but for medicine as a whole. Thank you all so much for listening. I hope you found this talk useful. Please feel free to contact me with any questions or comments. Thank you again.